Good morning. This is Wale Tolawi. So we are going to review our sedation forms, basically mainly for the pre-assessment, so just so that all clinical members of staff, including nurses and dentists, that we're all able to assess patients pretty much the same way. We're singing from the same hymn book, and also to be able to assess patients remotely so that we can get as much information as possible out of the patients prior to them coming for their treatment. Okay, so we'll get on with the form. First of all, when we call up the patient, we introduce ourselves to the patient. Yes, I am, so and so, calling from so and so clinic. We're just calling you basically so we can get through your pre-assessment prior to you having your sedation done. Okay, so on the day of the pre-assessment, we enter the date. We seek verbal consent from the patient that if it's okay for us to do their assessment. Obviously, they are going to say yes. If they say no, we are not able to carry on with the treatment or with the assessment. Okay, so we put the patient's name first. So let's say the patient's name is John Adams. It's best to put the patient's first name in small letters and their surname in capital letters, so that helps us to know which name is the first name, which name is the surname. We put their date of birth as well, so let's say that is the 15th of June 1976. Okay, and then gender, age, basically, so we can put something like M 46, whatever age their age is. The patient's ID we can get from the computer. That will be something like maybe 30765, something like that. This little circle here pretty much represents the gender, age as well. Sometimes I will just put something like, instead of M46, I could just put something like 46M. Or if the patient is a 23-year-old patient having a wisdom tooth out, I could just put something like 23, like that. Basically, it just gives us lots of information as we go along. Now, in this little section here, it's a very good idea to ask the patient the reason what's the reason why they're having sedation. Some patients will tell you, I didn't even know I'm having sedation. I was just told to contact the practice to have my tooth extracted. In which case, we would then ask the patient, do they really want to have sedation, or they're happy to have it under local anesthetic? If they say they're happy to have it under local anesthetic, it saves us going through all these sedation bits. But if they say, I had a bad experience, I do want to have sedation, or I've got a dental phobia, I have fear of needles, then you can obviously just put the reason there, maybe fear of needles, or maybe something like a previous bad experience. We do try and talk patients out of having sedation. If they insist they want to have sedation, we just put the reason there and then we carry on. So this first pink band here is something we can't do over the phone. So we see the pink band, we just have to skip that bit, but we do it on the day the patient comes for their sedation. If the patient is actually attending the practice for sedation for the pre-assessment, then of course we can do it on that day. We'll check their oxygen saturation. We do that with the pulse oximeter, and their heart rate as well. The pulse oximeter will tell us what their heart rate is. So obviously, we've got a little image here, a little icon here for the lungs. We usually will be about 94 and above. If it's below 90, then we have concerns. The heart rate usually is in the region of, and a normal basic heart rate is about 72 beats a minute. However, on the day the patient comes for the assessment, it will be a bit higher because there's a little bit of anxiety. If we're going above 100, then we should start getting a bit concerned. If it's dropping below 60, we should have an idea why. But, we just need to record all these things. The blood pressure, we will check with this fig. Obviously, that again, remember, we can't do these bits over the phone, so we can't do this remotely. So we'll do this in the practice, and we record the blood pressure. Blood pressure normally is about 120 over 80. If the systolic is rising, is quite high, basically we're starting to go to 160, 170, 180, or more so the diastolic is over 100. We're going to 110, 120. Basically, we should be referring that patient back to the GP to review their blood pressure. If we have a high blood pressure on the day we're doing the recording, we should record it about 2 or 3 times. If it remains high, then we send the patient back to the GP and we won't proceed to book the patient for sedation. ASA score, we can do over the phone, basically within the scope of our practice. Our score basically should be 1 or 2. An ASA score of 3 and above basically will be out of the scope of the practice, and again, we should be sending the patient to hospital. The IOSN score basically is a score out of over 25. This one basically is where the patient, normally the dentist would have done that basically to see the higher the score, the more likely the patient will need sedation. If we ask the patient basically the questions on the ISI score, it will get closer to 25 basically, as 25 over 25. I'm a bit wary of this score basically because a patient will always exaggerate their the level of anxiety, but we can record it, but it's not a major prerequisite for pre-assessment for IV sedation. So the attending nurse, the nurse who was, if it's being done in the clinic, if the pre-assessment is being done in the clinic, so we put down the name of the nurse, Molly or Daniela, or maybe Jan or whoever is attending the clinic on the day. And then of course we must record the name of the person who is doing the consultation. It may well be the nurse, maybe Jan or myself or whoever is doing it basically. We just put our name there. Okay, this bit basically is important for mainly obese patients. This is to calculate the BMI. A patient who's like of normal height and normal body build, it's not terribly essential, but if we have a large patient and an obese patient, we need to know the BMI. So obviously we will get their weight. Some patients will give you their weight over the phone and their height over the phone, so it's something that could be done over the phone. But if on attending the clinic, the patient is obese, we need to check the weight and the height, and then of course we can calculate the BMI. The weight, it could be metric or imperial. It doesn't matter, so it could either be in kilograms or stones. The height could be in feet and inches or in centimeters. It doesn't matter, it'll still calculate. We'll still be able to calculate the BMI. If we have a high BMI basically of 40 and above 40 and above, then we'll basically start having to consider with the clinician whether it's going to be a good idea to sedate the patient. A lot of patients will tell you that they have been previously sedated in the past and that they never had any problems. So anyway, that is going to be a judgment call for the clinician. Okay, next we come to the purpose or the reason why the patient has been referred, or what treatment they're supposed to be having done. In most cases it will be for an extraction, so we'll take the extraction, or it could be something else. Maybe they're having an apicectomy done, or we have a few orthodontic cases as well, maybe an exposure and a gold chain bond of a canine or a premolar, or they're having a frenectomy. If it's a frenectomy, we'll just take it, and of course it's not a bad idea to put an arrow if it's an upper frenectomy. In most cases an upper frenectomy, very rarely maybe a lower one. Or if it's anything else, maybe like a biopsy, we can just take that and say biopsy, and then maybe we'll just put lip. You can never put too much information on the form. And then of course, so they're going to have sedation, so the treatment is under local anesthetic with conscious sedation. Please, if we are doing an extraction or an apicectomy or pretty much any procedure except the soft tissue ones, even during pre-assessments, it's always a good idea to have x-rays at hand. OPG is obviously by far the best, and then we will then record here what the patient is having done. Maybe they're having an extraction of maybe an upper right 5, lower left 6 or something like that, or they're having multiple extractions, 2, 1, 1, 2, or they're having maybe an impacted wisdom tooth. When I put my wisdom tooth, I always like to look at the x-ray and just put a little arrow to indicate whether it's a horizontal wisdom tooth or mesioangular wisdom tooth, that kind of thing. Another good reason why we like to have x-rays is we want to see if the x-ray is adequate or not. If the x-ray is not adequate, it's a good time then to send the patient back to the dentist to have appropriate x-rays done. Like for instance, wisdom teeth, a lower wisdom teeth, can we see the ID nerve showing on the x-ray? If it's not showing there, then well, maybe we want the patient to get their dentist to do an OPG, or we're going to do an OPG ourselves in the practice, or do we need a CBCT scan, anyhow. So this bit is very crucial. Medical history. With the referral, have we got a medical history attached? Please look out to see if it has been attached, and make sure you see it yourself. If you've seen it yourself, put a yes. If you haven't seen it, just put a no. And then we ask the patient over the phone, or if they're there, about their medical history. We always want it in writing. This is crucial. You may have several patients having the same procedure done, but their medical history is never the same. So we go through a detailed medical history. We want to know about the past medical history, previous hospital previous hospital admissions, so admissions, operations, and anything else of relevance. Okay, medication is extremely important. We want to know what medicines the patient is taking. Every medication they're taking is crucial. Basically, we'd like them to bring a list of their prescriptions with them when they are coming. Some patients consider some medication not important and they won't mention it. Some patients, for instance, they don't think inhalers are medication, or even things like vitamins. We just basically want them to give us a list of every single medicine they're taking, and of course, please bring a copy of their GP prescription along with them. Okay. When we're checking patients' medication, some of the medication, we have to remember when they're telling us these pills over the phone, some of the medications do sound alike. Amoxicillin, which is an antibiotic, sounds a little bit like amlodipine, which is for blood pressure, or penicillin, which is an antibiotic, sounds very much similar to penicillamine. So basically, these patients, they are patients, so the onus is not on them to actually give us the proper names of these medications, but at least that's why we want them to bring the prescriptions along with them. Okay. Any known allergies? Yes, whatever they're allergic to, we just tick the box, and of course, we would like to know what it is they are allergic to. And we'll just write. Just tick the box and see. We just write what medications they are allergic to, or we can just simply put non-known. Non-known is not the same as none. Non-known basically means there's nothing they're allergic to that they're aware of. Okay, social history. Patients, do they smoke? Yes or no? If they do smoke, we want to know how many a day. It's of major relevance because we're sedating these patients. The higher the number of cigarettes they smoke, or the longer they've been smoking, the more damage they have to the lungs, the less likely our sedation will work. Also, patients who smoke are a bit more resistant to benzodiazepines, which is what we use in our practice to sedate patients with. Midazolam is a benzodiazepine. We don't use ketamine. We don't use propofol. So, but anyhow, we just want to know. A lot of them basically will tell you they don't smoke, but they vape. Okay, so if they're a past smoker or they've never smoked, basically, so we want to indicate that. Alcohol. How many units a week? Basically, a lot of patients get confused, or we don't know how many units basically, but they'll just give you a figure. Those figures are never exact. Basically, there's so many types of alcohols out there. So anyhow, we just put how many units a week. Females, on the average, are supposed to take up to 14 units a week. Adult males, 21 units a week. But so we just know. If patients are having heavy consumption of alcohol, it's of relevance basically because of possibility of liver damage. And of course, another important thing is patients who consume alcohol. Remember, for sedation, we don't want them to take any alcohol 24 hours before and 24 hours after. So that is important. So this alcohol, we want to know how much alcohol they're taking. Recreational drugs, basically, yes or no. Of course, cannabis now is just, it's everywhere. So we want to know if they're taking recreational drugs and what kind of drugs they're taking. Some of them basically, will take other recreational drugs. So we want to know what drug it is they're taking. Patient's occupation is important. Sometimes basically we could have a patient who is even a doctor or a dentist. So that is important basically, because obviously, well, for every patient we want to know what we're doing, but a bit of professional courtesy there. If the patient, for instance, is a lawyer, we need to step up our game, litigation, that kind of thing. If the patient basically is a driver or a machine operator, we want to stress the fact that, well, this is what we tell everybody anyway, but some certain professions, there are some more some aspects of the treatment that we need to stress a bit more important to them. For instance, a patient who is a driver or a machine operator, we have to stress they're not allowed to, they can't drive for 24 hours after sedation. We tell everybody this anyway, but occupation is important. Okay. Now, stress scale, it's okay basically. I find most patients will hover around this region, but if you ask a patient, when you're having your dental treatment done, how stressful do you find it? A lot of them will tell you it's 10 plus. I don't think so. If a patient is on the scale they're 10 plus, believe you me, when you're talking to them, they'll be shivering and shaking and sweating and all the rest of it. But anyway, it's there to be asked. Okay, so previous history. As a patient had a general anesthetic before, if a patient had a general anesthetic before, they're quite likely to have had a sedation in the past, because before general anesthesia, they're given a pre-med. The pre-med itself is sedation. Local anesthetic, we'll ask them if they've had local anesthetics before, not necessarily dental, but if you look at the OPG and you see big fillings there or root canals or previously missing teeth, they're most likely to have had local anesthetic before. Conscious sedation, we want to know if they've had sedation before, so at least it gives us an idea that they know what to expect. If they've had conscious sedation, a lot of them will even say, oh yes, I've had conscious sedation before, I even had it in this practice. So we can check their records and at least give us a bit of an idea of how they responded to the sedation and what to expect. Okay, right. Now this is the examination bit. It's impossible to examine a patient over the phone, but if they're in the practice, of course we can do a detailed examination. Even over the phone, if you are discussing with the patient by video, you can still see a few things like facial asymmetry or swelling, that kind of stuff. But anyhow, this can only be done properly in the clinic. Extraorally, that means outside the mouth. We're just looking to see if the patient has any swollen lymph nodes. Common site for lymph nodes is under the mandible, right side. We just feel for lymph nodes. If we find any lymph nodes there, we just tick them. Are the lymph nodes swollen? Are they tender? Is it just one lymph node or multiple lymph nodes? We put all that information there. We have a look at the patient's lips. Common thing basically is if the patient, things like cold sores. If the patient has cold sores on the day of the pre-assessment, it's not of major relevance because we're not treating them on that day. But we have to let the patient know that if they have cold sores on the day of the treatment, we can't do it. Cold sores obviously is a viral infection of herpes simplex, is highly contagious, so we can't treat a patient who's got cold sores. Other lesions obviously can affect the lips, if you have discolorations, facial, lip asymmetries, lumps, bumps, cysts, that kind of thing. Any other form of facial asymmetry, is one. Usually would mainly be things like swelling. If the patient basically has had a stroke, then there will be a droop on that side of the face. There's all sorts of things basically. So we just always inspect the patient extraorally. TMJ is also extraoral. We don't place a lot of emphasis on TMJ. We should do basically, we'll just check the joint basically. Common thing basically is clicking. Other things basically can be tenderness, or if the patient has a restricted opening, basically can just be due to a problem with the TMJ, or when the patient is opening the mouth, the jaw skews to one side, basically it's normally due to TMJ problems basically. So, and we just indicate whether it's the left side or the right side. But most importantly here is if the patient is able to open their mouth, whether we're going to have restricted access, to do our procedure. Okay, intraorally, that is inside the mouth. So we've got the soft tissues and hard tissues. So soft tissues basically That's what we got this little diagram here for. So this is the tongue here. This is the dorsum of the tongue. We're having a quick look at the dorsum of the tongue. And we also have the lateral borders. Do we have like things like ulcers? Are they traumatic ulcers from the patient's biting? Are they malignant ulcers? Do they look sinister? We can have ulcers pretty much anywhere, anyhow. So this is the dorsum of the tongue. This is the right cheek, left cheek on the inside. That's the mucosa, as in the mucous membranes. This is the upper lip. We've got the corners of the mouth, and of course, this is the base of the tongue. The tongue is flipped upwards. We've got the base of the tongue. We've got the floor of the mouth, and we've got the lower lip, mucosa of the lower lip. Again, so we're looking for lesions. We're looking for red lesions. We're looking for white lesions. We're looking for ulcers. We're looking for swellings. We're looking for pretty much everything. Whatever we find, we record. There's so many things. The tongue's got thousands of lesions, basically. Hairy tongue, strawberry tongue, geographic tongue, whatever, basically. So whatever we find, we just record them. Roof of the mouth, hard palate, soft palate. Again, pretty much we're looking for ulcers, swellings, asymmetry. On the gums, the back gums on the posterior teeth, anterior teeth. Well, of course, this is pretty much what we're finding here. So we can just write them here. We indicate them on the image here. So with the gums, basically, there will be we'll find lots of periodices. Periodices, there's lots of tartar, plaque, basically. So pus, bleeding, pockets. We can't go too much to town, basically, because obviously what we're doing is an assessment for sedation. So we're not doing a full perio assessment, So with the hard tissues, basically, caries, broken teeth, fractured teeth, split teeth, whatever we find, basically we just indicate the mobile teeth, that kind of thing. So basically we'll just put whatever information we find there. Our investigations. So investigations, obviously, more important than anything else is our radiographs, OPGPAs. Basically, please check to make sure that the radiographs that are sent are those for the patient. We have had situations whereby the radiographs do not tally with the treatment requested of the patient, or it is even the radiographs of the wrong patient. If we have wrong radiographs, ideally we should send that patient back to the dentist to send the right radiographs, not just take our own radiographs, because there may also be confusion or a mistake on the treatment that's been referred. If the treatment the dentist has referred doesn't tally with the treatment the patient is supposed to be having done, we have to return that. We send the patient back to the dentist, for the right diagnosis and the right treatment plan. Okay. We should have here photographs as well, because sometimes we take photographs. Photographs are just as important as radiographs, so we should have that on this list as well. Vitality testing mainly is an endo thing, so not so much so for oral surgery. Our sedation clinic is mainly for oral surgery. Endo has its place, basically, so, for instance, if we have a patient that has been referred for an episectomy and an RCT hasn't been done, we can do a vitality test and then maybe refer the patient back, to have endodontics done. Maybe episectomy may not be necessary, but if they've got a tooth with a big fat cyst, obviously, then we will have to proceed after a root canal is done and then do the episectomy. Intraoral imaging, basically, again, that is PAs and photographs, So CBCT scan is obviously a very important investigation, but that is not just like an OPG. It's not intraoral, but anyway, we should have it on this list. Again, in intraoral x-rays, both intraoral x-rays, extraoral x-rays, which if there's any periapical radiolucencies, we just indicate them which tooth, just roughly maybe the size of the radiolucency. We can say small, medium, or large. Ideally, we should say maybe about 3 centimeters by 3 centimeters, but, this is just a quick assessment to see if the patient is suitable for sedation. So we don't want to go to town too much. radiolucency suggestive of caries. Basically, sometimes the x-rays, we can have artifacts, so if we've got a tooth, if there's a carious lesion, we just say image suggestive of caries, So anyway, there we go. So inside the patient's mouth, we want to see if they got any removable or fixed appliances. Removable appliances usually things like dentures, or maybe they have aligners, that kind of thing. Fixed ones, crowns, implants, splints, da-da-da. I always like to mention if they've got something like a tongue stud, or there's all sorts of things there now. There are bows, studs, and rings, and all sorts of stuff. Basically, we'll just make an indication of them. Additional notes usually is pretty much more or less the summary. So it could be like a 75-year-old gentleman with a history of maybe had a heart attack, and a hip replacement, and a COPD for surgical removal of lower right 6. And then upper left 7 roots under LA, or it could be something like a 34-year-old lady for surgical removal of both wisdom teeth, fit and healthy, to be done under LA. Okay, now this patient information for sedation, before we let the patient go, we have to tell them, even if it's over the phone, the do's and don'ts they need to have for this on the day of sedation. They need to they need to have staff for 4 hours. They need to come with an escort. They need to have some means of transport. If they do take alcohol, no alcohol 24 hours before, 24 hours after, that kind of thing. When they go back home, they have to have somebody, an escort. I mean, not an escort, a responsible adult, could be the same escort, so stay with them for 24 hours, that kind of thing. So all the information is on a leaflet. We'll just give them that information, and then of course we ask them if there's any questions they want to ask. Okay, once all that is done, this we should take basically just to our checklist to make sure, yes, we saw the medical history form, we give them all the information for sedation, which is here, consent for radiographs, consenting for treatment for sedation, and for the procedure itself under local anesthetic. Just basically we need to get all this information. We should get the name of the chaperone and the relationship to the patient. Basically, this could be a major legal issue for the future, basically. So once they've got all of this, and then of course the assessing member of staff should then sign that, basically, and just put the dates, 2nd of January 2026 or whatever. Okay, remember this form is by no means complete until the detailed examination is done. Also, this discussion we're having now is not a complete discussion on what needs to be done with pre-assessment. There's loads of bits and pieces, that we could add on, and no two patients are the same. So these are just basic guidelines on what we need to do on the day of the pre-assessment. So if anybody would like to add some more contributions, basically, please by all means do so. And I think in another year's time, we should review this again and just do some modifications, just so we can improve the quality of our services. I'd like to thank everybody very much, and thanks for listening to my boring voice. I am now going to drink some coffee and go away. Thank you. Bye-bye.